other things. Okay.
Thank you, Nevo.
See you.
Thank you, Professor, so for these nice words. Okay, so it's 6 p.m. here in Belgrade shop, so we will start with today's lecture, and welcome to everybody. So thank you for joining us to the summer final of the Belgrade Sports Medicine e-forum activities. So this is today the last lecture for this summer season. We will come back in autumn. And this end of our summer forum will be in some kind of the cardiological manner. Today with us we have as a lecturer Dr. Carmen Adamuz, that she's working currently as the cardiologist consultant at Aspetar Clinic in Doha. Dr. Adamuz is a Spanish-trained cardiologist that has extensive experience in both the clinical and sports cardiology. She also has a tremendous experience coming from field because she worked a lot as the medical chief in various international top level sports competitions. Previously, Dr. Adamuz worked as the director of the Centro Andaluz de Medicina del Deporte and also as the head of cardiology unit at the Complejo Hospitalario del Han in Spain. The title of today's lecture is Cardiovascular Considerations for the Return to Play After COVID-19. So some really burning subject that is happening today. So without further ado, Dr. Adamuz, you can start with your lecture, and after that we will proceed with discussion.
So good evening. Thank you very much for the kind invitation to be part of this forum today. It's really a pleasure and an honor for me to be here today. I have no disclosures in relation with the presentation of today. This slide is just from a few hours ago. It's the data from the Johns Hopkins University. As you see, the burden of COVID-19 disease has really evolved very rapidly since it first appeared in China in December 2019 and was declared pandemic in March 2020. More than 9 million people is affected around the world, and this disease is really challenging not only the public health and healthcare delivery around the world, but also all aspects of society, and it's having a huge impact in elite sport, with some of the top elite athletes testing positive for COVID-19. The question is how we should evaluate athletes when they test positive for COVID-19 and they have to return to normal sport, because we know in many cases COVID-19 can really cause serious cardiovascular complications. So the aim of the presentation of today is going to be basically to summarize which are the most important or significant cardiovascular complications of COVID-19 and what are the potential consequences in athletes of these complications, and review which are the available recommendations for the cardiovascular assessment of athletes after COVID-19 disease before return to play. I think we are all familiar with the epidemiology of COVID-19. I would like just highlight that the virus causing the disease, SARS-CoV-2, is highly infective, and that data from the CDC from China with more than 72,000 patients describe different forms of presentation of the disease, with majority of the cases, more than 80% of the cases, mild forms of disease, mild symptoms and specific symptoms accompanied by lymphopenia. 40% of the cases will have severe disease, pneumonia requiring hospitalization. Up to 5% of the cases will be in critical conditions affected by acute respiratory distress syndrome and distributive and cardiogenic shock. We know that some of the population are at higher risk of severe disease. And this population specifically include cardiovascular, those with cardiovascular disease and hypertension. And we can think, okay, our young athletes are healthy individuals, but We have to remember hypertension is the most common cardiovascular condition observed also in young athletes. And we have athletes with cardiovascular disease, even young athletes. And of course, master athletes and recreational athletes are at high risk of severe disease. If you see the case fatality in cardiovascular disease and hypertensive individual with COVID-19 is much, much higher. So before going ahead with the clinical manifestation of in the cardiovascular system of COVID-19, I think it's very important just to try to understand why these cardiovascular complications happen. And so if you allow me during the next 3 slides, I will go to review very slightly the pathophysiology of COVID-19, because it's really the key question to understand all the clinical consequences. We know that COVID-19 is caused by SARS-CoV-2, which is only one single RNA gene virus that uses as an entry in the cell the angiotensin converter enzyme type 2. This is a very important protein found in the membrane cell, which has significant regulatory properties in the RAS system. The RAS is the renin, angiotensin, and aldosterone system, as you are familiar with. And if you remember, this system is activated in situation of severe hypotension. When there is severe hypotension, the kidney release renin that convert the angiotensinogen, a protein released by the liver in angiotensin 1, and the AC1, the angiotensin converter enzyme type 1, convert this angiotensin 1 in angiotensin 2, which through vasoconstriction will increase the blood pressure. The long-term consequences of angiotensin 2 are nonetheless not very good for the body, because it increases inflammation, fibrosis, proliferation, and produce hypertension, cardiac fibrosis, thrombosis, and acute respiratory distress syndrome. This is why there is a counterbalance system in which AC2, the protein that uses the virus as a cell entry, it's very important and help to convert part of this angiotensin to angiotensin 1 to 7, which has very beneficial effects on the body, reducing the blood pressure, reducing fibrosis, thrombosis, and improving the respiratory function. So it has vasodilation, anti-apoptotic, antifibrotic, and anti-proliferative actions. The problem is when the virus uses this protein to join the cell, and we lose all the benefits of the angiotensin 1 to 7. This regulation on the RAS system creates that the predominant effects of the virus in the body will be increased inflammation, fibrosis, thrombosis, and distress respiratory. So what happened when the virus link to this receptor, the angiotensin converter enzyme type 2 receptor? Well, the initial location of the action is the lung, as you know, and it increases inflammation locally in the lung. This local inflammation will activate T cells and macrophages. These macrophages and T cell activated can migrate to the myocardium and can actually trigger some of the most severe cases of myocarditis observed during the course of COVID-19 infection, which fulminant myocarditis, severe heart failure, and cardiogenic shock. But it's also, the myocardial cells also have receptors for the virus, also have AC2. And there is a description of direct invasion of the virus in the myocardium that also contribute to the myocardial damage. This is observed in the plasma of the patient with release of the biological marker of myocardial damage, which is the troponin. So elevation of troponin together with abnormalities in electrocardiogram or echocardiography can manifest this myocardial damage observed as a result of the direct invasion of the virus in the myocardium. Consequently, it will increase the dysfunction of the heart and can lead to the presentation of arrhythmias in patients with COVID-19. There are also effects on the vascular system because the endothelial cells have also receptors for ACE2. So the action of the direct invasion of the virus on the endothelial cells can affect both the microvessels and the coronary arteries. And this create microvascular dysfunction in patients with, with coronary artery disease or with arteriosclerotic plaque can trigger endothelial dysfunction and acute coronary syndrome. So this is another mechanism of cardiovascular damage, the triggering of acute coronary syndrome in patients with COVID-19. To make things a little bit more complicated, the activation of the inflammatory response in the body due to the local inflammation in the lungs create this cytokine storm with hypercoagulability status that contributes secondarily to make worse the thrombotic complications, appearance of thromboembolic events and thromboembolic pulmonary complications in patients with COVID-19. And just to make a little bit more complicated things, the difference between the oxygen demand and supply create a mismatch that trigger, again, acute coronary syndromes, what we call acute coronary syndromes type 2 or acute myocardial infarction type 2, which is not due to the rupture of an acute, the acute rupture of an arteriosclerotic plaque, but it is due to this mismatch between the need of oxygen in the myocardium and the supply of oxygen in the context of severe hypoxemia. So all this is very complex, and this is the trigger for the different manifestation of myocardial damage, thromboembolic events, arrhythmias that we observe in patients with COVID-19. Yeah, I understand this is a little bit complex, so please just breathe, relax a little. So all this complex myocardial injury leads to a very difficult scenario. The scenario is that we see patients with elevation of troponin. In some cases, up to 20%, 28% of the patients hospitalized with COVID-19 have elevation of troponin, abnormalities in the electrocardiogram and in the echocardiography that are manifestation of this myocardial injury. And these patients are clearly at high risk of worse outcome. They go to the intensive care unit more frequently, and they die more frequently. Up to 51% of the patients who die with COVID-19 have evidence of myocardial damage, being responsible, this myocardial damage of the death of the patient up to 7% of the cases. But if you look at this graphic that you have below, you will see in blue the level of troponin that is observed in patients that survive the infection of COVID-19 versus the level of troponin observed in red in patients that died of COVID-19. Okay? This is the umbral of normality, what we consider the 99% percentile of normality in troponin. So it is interesting to observe that approximately on the 7th day of disease is where the troponin start to be significantly elevated in plasma in those who are going to have a worse outcome. And it will be around the 2nd week of disease when elevations really reach significant level, and it will continue elevating in those who die. This is important, and this is important because troponin has been recommended to be used in the screening of athletes after COVID-19, but we need to know what we are measuring and in which cases the measurement of troponin is relevant or not, because most likely athletes with a very benign course will have a completely normal level of troponin, because, but in other cases, those who have elevation of troponin during the clinical course will be for us a little bit more of concern. So what to expect in relation with myocardial injury in athletes? Well, to be honest, myocardial injury is still a black box in individual patients. So we really don't know if there are some subclinical myocarditis, see if we can expect some subclinical myocardial damage, even in asymptomatic or even in mild form of disease. It still is completely unknown. If we find evidence of myocarditis, that must be explored not only with elevation of troponin, ECG or echo, but it is recommended to go ahead to complete the diagnosis with cardiac MRI, and the gold standard would be also to perform a myocardial biopsy if possible, but almost cardiac MRI is necessary. As I say, if there is evidence of myocarditis, the restriction for sport participation, it's going to be during a long period, and it is recommended to follow currently the guidelines between 3 to 6 months, depending on how has been the myocarditis, if there has been significant left ventricular dysfunction associated to the myocarditis or not. It will really require longer period of stop all kind of sport participation. After what, we will complete a new cardiac assessment, and some athletes may not be allowed to return to play never if the condition became irreversible. Potential long-term effects of myocardial damage are very important, and we already know from other cases of myocarditis is the scar tissue in the myocardium, the myocardial fibrosis, which is associated with high development of ventricular arrhythmias, sudden cardiac death, and in some cases also development of heart failure in the future. So those athletes that may have a more significant and worse course of acute COVID-19 disease may be affected of worse outcome also on the long term. But apart from this myocardial involvement, SARS-CoV-2, it's a very important source of arrhythmias, and not only in relation with myocarditis, but also there are different causes for these arrhythmias. One important cause of arrhythmias in patients with COVID-19 are the administration of drugs like hydroxychloroquine and lopinavir, some of the antivirals that we are using to treat COVID-19 that are prolong the QT. In patients with ion channel disease like long QT syndrome, the administration of these drugs can trigger severe ventricular arrhythmia. So we have to be very vigilant because it has been involved in some of the cases of sudden cardiac death in patients with COVID-19. And also we have to remember that those with Brugada syndrome may have also ventricular arrhythmias during episodes of high fever. So the management of fever in cases of Brugada syndrome is very important. And in the long term, one of the most important consequences of complications that I consider we have to bear in mind in athletes also is the episode of venous thromboembolism, pulmonary embolism that will cause right ventricular overload. It may cause pulmonary hypertension, not only during the acute phase, but also it can trigger the development of pulmonary hypertension in the long term as a chronic disease. And it's very interesting that the right ventricular damage in patients with COVID-19 can be described even as a different entity to the myocarditis affecting the left ventricle. So, for example, in patients that has been discharged from the hospital with COVID-19 and returned to consultation because they have cardiac symptoms, it has been observed that up to 58% of the cases present diffuse myocardial edema. These patients didn't have myocarditis previously. These patients were patients without any cardiac disease, and they have this diffuse myocardial edema associated with impaired right ventricular ejection fraction, while they preserve normal ejection fraction on the left ventricle. So it seems that the mechanism of right ventricular dysfunction, it's very complex, and it can involve not only myocardial injury and myocarditis, but also overload due to the respiratory disease, overload due to thromboembolic events. And of course, we have to consider also the role of some possible pre-existing conditions, especially in cases of arrhythmogenic right ventricular cardiomyopathy or cardiomyopathy that is right ventricular cardiomyopathy that has been described also in athletes, in endurance athletes. So the right ventricle has to be very thorough evaluated in athletes with severe disease during the acute phase, but also in those that don't have or didn't have very severe disease, but continue having some cardiac symptoms, palpitations, or chest pain. Which are the potential long-term consequences of COVID-19 apart from the myocardial involvement? Well, we really don't know, but we know that acute myocardial infarction, the risk of acute myocardial infarction is increased in people after influenza infection and after infection by other coronavirus. And this risk is significantly elevated during the next 12 to 24 months. And also has been described by the University of Pittsburgh that patients affected by pneumonia, severe pneumonia, may have an increased risk of cardiovascular disease during the next 10 years. This risk is significantly higher during the first year, but it remains being elevated over the next 9 years. So will patients after COVID-19 disease have an increased risk of acute myocardial infarction or cardiovascular disease? We really don't know, but we will follow them. Very important is the pediatric population. Pediatric patients are much less affected than the adult population. Only 2 to 5% of the affected patients with COVID-19 are pediatric patients. And the distribution of disease in the pediatric population is a little bit different than in adult population, with up to 40% of the cases with moderate symptoms. And what I want to highlight is that we have many pediatric athletes. We have teenagers, and we have all population under 19 that has been described to be affected by Kawasaki-like disease on the onset of COVID-19. So this population, if affected by COVID-19 or young athletes, will require very specific assessment, especially looking into the coronary arteries if we can observe any abnormal dilatation or aneurysm as a residual effect of the Kawasaki-like disease in this subgroup of athletes. So how are we going to manage our athletes during the ongoing COVID-19 pandemic? I think this is a very dynamic approach. We will have most of the athletes will be initially negative, and many of them will become positive with the time. I think the management should be for when the athlete is negative, we have to give them the general recommendations for prevention of disease that we give to all the public, especially important for them to monitor for appearance of any symptoms, and they can exercise without any restriction, even if they have to be under confinement and not training with the club or with the federation, or they can return to play normally after the confinement without any restriction. They don't really need any cardiac assessment. I think what is important is to highlight that there are some kind of athletes that may have some cardiovascular condition, like hypertension, for example, they deserve some specific type of monitoring, even self-monitoring or remote monitoring, the assistance of telemedicine, to be sure they receive the appropriate care, they receive medication if needed, and just to be very alert and vigilant if they develop the disease, because we know they may have a more severe form of COVID-19 disease than those without a cardiovascular condition. Once athlete became positive, what we have to do? Well, we have to monitor for symptoms and evaluate for cardiovascular complications. It's very important that they respect absolute resting period during the symptomatic phase. It's very important because we know that the development of myocarditis is increased in those that exercise during viral infections. So it's very important to educate athletes if they start to have symptoms to completely stop training. They should be resting. The recommendation is up to 2 weeks once the symptoms completely disappear. And this is the moment for us to evaluate any cardiovascular sequela, especially myocardial injury or thromboembolic disease. In those athletes with cardiovascular condition, if they became positive, they will require very closer monitoring just to prevent or to detect if there is any worsening appearance of any cardiovascular complication during the course of the disease. It's very important if they are taking medication to evaluate if there is any interaction or toxicity with the medication provided to treat the COVID-19 disease, and of course, prevention of arrhythmias in long QT syndrome, Brugada syndrome. You may say, well, yes, but we don't have athletes with long QT syndrome or Brugada syndrome. Well, yes, we do. We know that some athletes, even when there are recommendations that there may have some restriction, there are nowadays more flexibility on this recommendation. And we have athletes with long QT syndrome training, and it's very important that they have proper education on their disease, and they can advise also on they can alert on the disease if they have to be treated in a hospital. This is a summary of the recommendations given from different experts on what to do with asymptomatic, mild symptomatic, or moderate or severe cases of COVID-19 athletes when they have been discharged to evaluate the return to play. Most of the recommendations can summarize in 3 recommendations. One given by Phelan that has been endorsed by the American College of Cardiology. The recommendations by Bati that from Sanji Group has been endorsed by the European Society of Cardiology. And I also would like to comment on the ASPETA recommendations. So if you see, there is agreement in between all the authors that all athletes, whether they have been asymptomatic or they have a severe disease, will require some kind of medical assessment before return to play. And there is also agreement, in all athletes, all authors, that severe and moderate cases of COVID-19, those that have been in the hospital with a severe condition, should require a very comprehensive evaluation, including echocardiography, exercise tests, Holter monitoring, troponin, cardiac MRI, to evaluate for any myocardial injury, myocardial damage during the episode. The most significant difference are in the management of asymptomatic and mild symptomatic cases. So for Phelan, the American College of Cardiology, asymptomatic athletes do not really require any kind of medical test apart from a general assessment. But in cases of mild symptoms, they recommend not only to do echocardiography, but also to complete a troponin test, troponin level test, which is, in my opinion, something really arguable, because if we have seen troponin, it's really elevated in cases of more severe conditions. And we know that the biology of the troponin is that it starts to be elevated between the 3-4 first hours of an acute injury to the myocardium. The peak is reached in 24 hours and starts 2 to 3 days after the injury, it normalizes. Yes, it can still be elevated up to 9 days in patients with acute myocardial infarction, but it's really very, very unusual that anyone with mild symptoms of COVID-19 disease will have elevation of troponin after 2 weeks of being completely asymptomatic. Bati, which represent the endorsement of the European Society of Cardiology, recommend that a symptomatic athlete can return to train 1 week after being completely asymptomatic. Most of the authors, and is the opinion of the experts in ASPETA, is that they should rest during the first 2 weeks because there are evidence of subclinical myocardial damage in acute infection. So we think it's better in this case to be a little bit more prudent and more conservative. Athletes, after having mild form of disease that have been sick during more than 7 days, will require echocardiography and exercise tests apart from a 12-lead ECG, but they don't include the need for the troponin. Let me go a little bit farther on these recommendations. There are other authors that I don't really mention. There are other experts, but I think the most important are those endorsed by the medical society, the cardiology societies. So this is this busy slide recommendation of Phelan that is endorsed by the American College of Cardiology. As in most of the recommendations, athletes that test negative for COVID-19 and are asymptomatic, they don't require any cardiology evaluation. Those asymptomatic with the disease have to rest during 2 weeks, have close monitoring for symptoms, and they can resume training without the requirement of any additional investigation, just basic assessment and questionnaire and physical examination. Those with mild symptoms, even when they have been not hospitalized, are those that I previously commented will require even troponin level, electrocardiogram, and echocardiography in the criteria of the American College of Cardiology. If these tests are normal, of course, they will continue being evaluated to detect myocarditis. Those with severe symptoms will have troponin tests during hospitalization, cardiac tests during hospitalization. When the tests are normal, they will have a new evaluation to consider return to play. If there is evidence of a myocardial injury with elevation of troponin over the 99% percentile and or any abnormality in the cardiac studies, they will be treated as a myocarditis and of course restricted from exercise during 3-6 months, as we previously commented. And this is the recommendation on the paper of Batia, which is the endorsement of the European Society of Cardiology. So all athletes are susceptible to have some kind of clinical history and examination, but only those with symptomatic disease more than 7 days should require any additional investigation that initially will be ECG and echo. And if these are normal, they recommend to complete a maximal exercise test before recommending returning to play. If all these investigations are normal, there are no restrictions. If any of them is abnormal, further investigations to follow according with the required. Those with debilitating symptoms or persistent cardiac symptoms or reduced performance when they resume to train will be susceptible for full cardiovascular evaluation, including troponin, cardiac MRI, exercise tests, Holter monitoring, and will be managed accordingly. We in Hospital developed our own internal clinical guideline on safe return to sport during the COVID-19 pandemic. I have to say it's a very comprehensive document with 65 pages. It is available in our website and you can download it. Even when the review date of the document is expected to be on the 31st of July, I have to say we already have started reviewing the document, and the current protocol that we are using for cardiac screening is a little bit different than the initial one. But basically, we recommend that patients with asymptomatic athletes without comorbidities after resting 2 weeks have also a cardiac assessment. And our recommendation is based specifically in two criteria. The first criteria is that we deal with elite athletes, and this is the protocol that we are going to apply to our elite athletic population. We screen them, we do periodic health evaluation in them every year. We have previous echo, previous ECG, we can compare, we can find any abnormalities. So this evaluation for us is part of also illustrate and gather more information on what to expect in athletes asymptomatic, whether we can detect or not any subclinical damage in relation with COVID-19 disease. I mean, research purpose and educational purpose for the future. And I think it's important that we can gather this information. We have the criteria to differentiate athletes with and without comorbidities and to apply different protocols. And I think no one in other guidelines give any consideration to previous comorbidities as an important marker to decide whether you stop here or you must do something else, even in asymptomatic athletes. So asymptomatic athletes with comorbidities, we consider they may require additional investigations. For example, in those that have been previously affected with myocarditis and are known to have already myocardial fibrosis, we think they require more comprehensive evaluation, including exercise tests and probably even Holter to detect if they develop arrhythmias, those with hypertension or history of cardiac arrhythmias, those with previous thromboembolic disease, may require different approach. So all these athletes, even asymptomatic, will require different approach and more comprehensive evaluation. For us, all athletes should rest 2 weeks, and those with symptoms should rest 2 weeks until symptom resolution. And of course, moderate and severe cases of disease will require a more comprehensive evaluation. And in those that during the acute phase of the disease didn't have any troponin elevation, ECG normality or echo normality, that means they didn't have any sign of cardiac involvement or during the acute process, we will proceed to do all the evaluation without further delay. But if there is evidence of cardiac involvement, we won't evaluate them immediately, but we will evaluate them after 3-6 months of resting, as recommended by the guidelines in myocarditis management. It's very important that we consider that some athletes may have specific recommendations. For example, those who had thromboembolic events during the COVID-19 disease, the return to play consideration should be very careful considered after very good evaluation of the right ventricle. And this may require also to test them during exercise with echocardiography and assess how is the pulmonary artery pressure and the right ventricular function during exercise. And very important, the current recommendation of the chest for athletes, for patients with COVID-19 affected by thromboembolic disease is to keep anticoagulation during 3 months. This will restrict athletes involved in contact sport to resume competitive sport participation until anticoagulation is completed. So probably your question will be, okay, so there are different expert recommendations because we don't really have any protocol evidence-based. These are all expert recommendations. What shall we choose to apply to our different athletes? I think this is very much going to depend on the testing capability that you are going to have, the resources that you have, the cost of the test, and the expertise required to provide reports of this test. So echocardiography in athletes, ECG in athletes, we know that requires some expertise, and it's even more complex to evaluate this test in athletes after COVID-19 disease. So it's important to have this expertise before evaluating athletes after COVID-19. And probably doing echocardiography by people not expert in the echo of athletes can even be more confusing. They can detect the features of the athletic remodeling and be unsure whether this is due to COVID-19 disease or this is something that the athlete already had before. So it's very important. And also important to decide which protocol based on the specific profile of the athlete. And this requires to know very well the clinical course of the disease, any comorbidity, and probably very important also to consider the scope of the sport participation. If this is a professional athlete, if this is a registered athlete, if this is an elite athlete, if this is a recreational athlete but involved in ultra endurance event, or it's just someone who does recreational sport just for health 2-3 days per week, 45 minutes each time. So probably the management could be tailored also to the scope of sport participation. Which consideration for you as a sport medicine physician and for us in sport cardiology have to bear in mind also when considering the COVID-19 impact on the routine periodic health evaluation and cardiovascular screening of athletes during this pandemic period? Well, some of the considerations are, should we test the exposure of SARS-CoV-2 in asymptomatic athletes coming for periodic health evaluation? Do we need to do PCR? Do we need to do immunoglobulin tests in all of them? And I think this depends of the first of the availability of tests that you are going to have in your institution, but also on how the result of these tests are going to impact the management and care of the athlete. If you have the protocol that in asymptomatic athletes, you don't really do any further investigation, probably you don't really need to do this test unless you want to have them for consideration to the clinical history of the patient, but it's not going to impact the management care. So it's very important to decide whether you do the test or not with one goal or another. Also very important is that up to date, we really don't know which are the long-term sequela of COVID-19. So it's very important that we monitor for any symptom development, even in those that have been very carefully evaluated. It's very important to educate athletes on any red flag symptoms they may feel once they resume training, like chest pain, palpitations, shortness of breath, dizziness, or syncope during exercise. And these patients will require additional investigation and more thorough and careful. So the routine periodic health evaluation should continue as usual. And we think that routine cardiovascular follow-up in positive cases is not indicated if the first assessment is completely normal. So we just do the routine periodic health evaluation, and we will do cardiovascular follow-up only in those with any of the abnormalities during the acute phase, myocardial involvement or arrhythmias, or etc. So as a highlight, just summary that most significant cardiovascular complications in COVID-19 include myocardial injury, venous thrombus, embolic disease, arrhythmias. We know that athletes with cardiovascular condition and hypertension may have higher risk of severe disease. We have to consider that this athlete may require specific management during the acute phase of the disease. Available protocols for return to play post-COVID-19 are based on expert opinion. The basic medical assessment before return to play is widely recommended by all authors in all cases. There is currently no consensus on evaluation of asymptomatic and mildly symptomatic athletes. The decision should be based on clinical profile, available resources, expertise, and others. And athletes with severe disease will always require very advanced and careful cardiac workup before deciding return to play. The long-term evaluation based on symptoms, monitoring, and periodic health evaluation is the most important recommendation. And a specific cardiology follow-up is required only in those in which we can observe abnormal findings in the evaluation. Just to finalize, I think we are really living in liquid modern life, and we must really be flexible and adapt. We know the circumstances are going to change. We will know a little bit more in the future, and we will have to change our protocols and our decisions as knowledge is developing. We gather more and more information on how is the cardiovascular effect in the medium and long term in athletes, in both the asymptomatic, the mildly symptomatic, and of course in those affected with more severe conditions. So I think it's the most important message now is that we really have to adapt to this liquid modern science and liquid modern period of COVID-19 pandemic. So thank you very much. I hope it wasn't very long, and I hope it has been useful for your knowledge on how to manage athletes with COVID-19 and cardiovascular evaluation.
Okay, so thank you, Dr. Adamuz, for this lovely presentation. So we really have heard a lot, and I think that with this lecture, we managed to dissolve some doubts that we have about return to play of the athletes, considering the cardiovascular status. I would like now to ask the audience to ask you questions. So there are two ways how you can do that. If you click on the participants section, you will find the option raise hand. So you can raise hand and turn on the microphone after I call your name and ask directly to Dr. Adamuz, or you can write down in the chat. And while we are waiting for the audience to choose the way how they want to ask you the questions, I would like to take the opportunity to say hello to some participants in today's audience. So we have Professor Kuidi from Aristotle University at Thessaloniki, who is also the cardiologist and the professor of sports medicine. So our labs are working together because they are also doing the examinations of the elite athletes in Greece. Also, we have Professor Gligoroska from Skopje. So like Serbia, Macedonia, Greece, we have the Balkan region, so united here today to listen to you. And we also have the Nikola Čirkis from the Olympic Committee of Serbia. So it is really important that like the top organization of the elite sport in Serbia was also present here with a member to hear today's recommendations. So I think that we gave enough time to our audience to come up with some questions. So we have a hand from Lana. Lana, you can ask questions.
Hello once again. Dr. Adamuz, thank you for your interesting up-to-date lecture. Also, I want to thank Professor Popovic and Professor Mazic for making possible this e-forum for us and for listening the worldwide expert in sport medicine. Also, it is very nice that one female doctor is closing our e-forum. I have to say that. I was eager to know the exact mechanism of pathology of raised troponin. Thank you for clarifying that for me. Nowadays, everybody comparing influenza with COVID-19. How much more COVID-19 affects heart, and can the level of troponin in influenza be as high as in COVID-19? Thank you.
Thank you, Lena, for your question and for your very nice words. I think it's interesting. Probably, we haven't been measuring troponin in most of the patients with influenza. So we are now measuring troponins in most of the patients in the hospital with COVID-19, but I guess we didn't do before in most of the cases with influenza. We are gathering information on effects of this virus on the heart that we don't have for previous virus. I can't really answer you how much is different in relation with the myocardial injury between both, because I think we haven't paid attention enough to the myocardial injury damage during the acute phase of influenza virus, and that's the reality.
Okay, thank you.
Yeah, thank you, Lana, for your question. We have a hand that is raised by Professor Sasha Buban from the Faculty of Sports and Physical Education at the University of Niš. Okay, Sasha, you can turn on your microphone and ask question to Dr. Adamuz.
Dear Professor Adamuz, thank you very much for this wonderful lecture. Many thanks to Professor Mazic, to Professor Popovic, and to Professor Đurić for including us into this wonderful cyclus that is ending. I hope we will continue our lectures in October. And I want to cite Federico García Lorca. Federico García Lorca dijo, nunca tenemos una segunda oportunidad para dejar la primera impresión. Por favor, cariña profesora Adamuz, entienda mi discurso como gratitud por una excelente primera impresión ustedes dejaste.
Muchísimas gracias. Thank you very much. These are very nice words. Appreciate it. Thank you. Very nice. I love Federico García Lorca. And
you
really
said everything. You said that several Chinese investigations determined that 7 to 27% of COVID-19 hospitalized patients would have some evidence of myocardial injury due to elevated level of blood marker troponin. You said that echocardiography should be an obligatory tool in athletes' assessment after COVID. You said that COVID-19 is related to myocardial fibrosis in some cases and ventricular arrhythmia. And my question is there any evidence of atrial tachycardia or some other type of arrhythmia? Thank you very much once again.
Thank you. Thank you very much. Yes, atrial arrhythmias are very frequent, and episode of atrial fibrillation even in patients after being discharged as a result of the myocardial edema or myocarditis. So it has been observed with high prevalence the appearance of all kinds of arrhythmias, not only ventricular arrhythmias, but also atrial arrhythmias. And even in mild forms of disease, some of the forms of palpitation described for patients have been registered as an episode of atrial arrhythmias.
Muchas gracias.
Welcome.
Okay, so thank to Professor Buban. Also, we have a hand from Milana Tomovic and one question in chat. So first to go through the people that raise hands. So Milana, you can turn on the microphone and ask Dr. Adamuz your question.
Okay, thank you, Beda. Hello, Dr. Carmen. It's very nice seeing you. Hi, it's very nice seeing you again. Thank you for this exceptional lecture. It's very helpful for everybody working in screening. And luckily, we have a lot of doctors today that their expertise is screening of athletes. And I wanted to add Professor Kuidi is here, and she's working also with patients and with cardiovascular rehabilitation. And I would like to ask you, should we use the same guideline for recreational athletes and for para-athletes? Should we have something special in mind if we work with this group of athletes? Do we have any data?
So your question, Milena, is recreational versus elite athletes?
Yeah, recreational versus athlete. And do we have some special consideration when screening para-athletes?
Yes. So precisely this is why in my presentation I explained there are different protocols, and we should use one protocol or another depending on different circumstances. For example, the availability of resources, and also the profile of the athlete, considering specifically the scope of practice. We in Aspetar have this guideline for elite athletes. If you ask me, will you use the same guideline for recreational athletes? Well, it depends on the resources that you have to manage recreational athletes. But if you don't have, if you cannot use the same recommendations, I think if you want to use the same recommendations for both populations, I think I will use the recommendation of the European Society of Cardiology, those endorsed by the European Society of Cardiology. These are the BATIA recommendations. Why? Because they are very practical. They are less dependent of many investors.
Dr. Carmen, I think that you freeze. I think we have an issue with internet at Dr. Adamuz. Everybody can hear me? Yeah, so we will see.
I can hear you, but I also can't see Dr.
Yeah, I
Carmen?
think there is a problem with internet at her place, so the signal is lost. We will wait a few moments for doctor to re-check. Okay, the connection was lost.
Could I?
Hello. So we have lost our guest, our lecturer. There is a problem with internet connection, so everybody can hear me and we can see and hear each other. We will wait a few moments for Dr. Carmen to reconnect.
Biljana.
I am back. I'm sorry, I lost the connection completely. I'm not sure if it was just me.
Yeah, there was just a lost connection, but we waited for you to reconnect, so don't worry. We are still here, all here.
Thank you very much for waiting for me. So, Milena, returning the question, if you have to use the same protocol, you have to be sure that you have the available resources to use for both populations. Otherwise, you have to tailor to different protocol to different population. If you want to use the same protocol, I recommend to use the European Society of Cardiology protocol, which is a more simple approach and more efficient for to treat or to evaluate a recreational and high number of population, more than the protocol that we use in hospital, which is probably more difficult to use in the big number of recreational athletes that may require evaluation, because it includes, even in asymptomatic ECG and echo, it requires expertise, medius, it is more costly and probably less efficient for those asymptomatics, unless you want to use them for research. But I definitely won't use the recommendation of the American College of Cardiology for everybody. No, I don't. And I think my personal feeling is that it is okay to use different protocol for elite athletes. They are elite athletes and probably some subpopulation of recreational athletes. And I already mentioned those involved in ultra endurance events. There are recreational athletes who really push to the limits. You know, triathletes taking part in Ironman competitions and all these kind of athletes who really may have already some form of associated form of arrhythmogenic cardiomyopathy, or some, you know, we know that some of these athletes may have some underlying abnormality. I will probably be more careful evaluating them. Otherwise, you can use the European approach, and it's more, yeah, I think it's more efficient approach for the recreational athlete.
Okay, thank you.
Welcome.
Okay, thank you, Milena, for your question. Professor Popovic, do you want to add something or?
No, thank you. No, I'm not expert in cardiology.
Okay, thank you. So from the chat, we have the question from Bruno Lori. Good evening, Maria Carmen, and thank you for this lecture. Currently, dexamethasone is showing his efficiency in treatment of severe forms of COVID-19 infection. Do you think it could reduce cardiovascular manifestations in athletes, and when should it be started? At what point in the course of disease?
About which medication is he asking?
Dexamethasone.
Oh, dexamethasone. Oh, quite interesting. Dexamethasone, there is something that, you know, dexamethasone is specifically very important in cases of cytokine storm to prevent all the damage due to the cytokine storm. I think most of the studies recommend that it is initiated in people after 1 week of disease, when the troponin level on the PCR and interleukins are really elevated in these cases. The outcomes of these patients are worse. So it shouldn't be initiated very early, very at the beginning of the disease, but probably after the first week in those with evolution to different, or I mean, evidence of worse outcome of more severe disease with elevation of interleukins, PCR, ferritin. These are markers of more activation of the immune system, in which dexamethasone can be more beneficial.
Okay, thank you for the answer. We also have a hand raised by Dr. Žarko Vučković. So, Žarko, you can turn on the microphone and ask a question.
Hola, Carmen. Gracias por tu presentación. I have a question regarding high blood pressure in athletes, and we probably don't have too many athletes with really high blood pressure, but is there a cutoff related to the symptoms, or is there like a linear or exponential correlation between like with the raise of high blood pressure and COVID-19 risk and complications?
Thank you for your question, Sarko. We actually have some athletes with very severe hypertension, especially black athletes, young black athletes. Some of them require up to 3 different drugs to control the medication, the hypertension. So it's not really very uncommon. I never saw in any paper any description in relation with a cutoff point for complications. And I assume most of the cases of hypertensive people affected by COVID-19, they were with the blood pressure very well controlled. Probably it is important to consider also the possibility that they may have some subclinical endothelial dysfunction, and this can trigger more severe disease in cases of COVID-19. It is important also to consider whether they have bad control of the blood pressure and there are some subclinical target organ damage in the heart or in the kidneys, because also it may be associated with worse outcome. But even in patients with good control hypertension, it's it's associated with higher mortality and worse outcome. And something important I didn't want to mention because it's complex, but maybe some of you have heard about this. There are some medication that we use to treat hypertension, inhibitors of the enzyme converter of angiotensin, and also the blockers of the receptors of angiotensin. So these 2 medications from the beginning have been very much discussed about the possible involvement of role on protection or against or damage in terms of or related with worse outcome in patients with COVID-19. And what we know up to date is, so far, all the recommendations we have by all clinical, all different medical societies in Europe and in the States recommend that patients taking this medication continue taking the medication. There is one paper that has been published quite recently by Valentin Fuster group, in which they evaluate the treatment with different drugs, anticoagulation, and these antihypertensive drugs in patients with COVID-19. And they have found that the treatment with enzyme converter of angiotensin inhibitors seems to be protective for worse forms of disease. This is so far the only news that we have on the benefit of this drug, really more consistent. But only the inhibitor of the enzyme converter of angiotensin. And this is important because maybe if now we have to choose a new treatment for someone with hypertension, in between the different drugs that we use, probably using this one could have some benefit for the patient in the current pandemic situation. But still, it doesn't mean the other drug, the blocker of the receptor of the angiotensin, it's not a good drug. Still, there's no recommendation to remove this treatment for the patients, but it hasn't demonstrated the same benefit than the other.
Thank you for your answer, and thank you for controlling my blood pressure, being my personal cardiologist and my guardian angel. Muchas gracias.
Thank you, Zarko.
Thank you, Zarko, for your question. We also have greetings from Professor Gligorovska from Skopje. She's saying that this was a beautiful lecture, that she really enjoyed it. So let me see if there is maybe some more question coming from audience. So here in chat, we have nothing, and there are no more hands raised. Okay, just let me check once again. So, because there's no more questions coming from audience, can you just allow me to ask one more? You talked about this possibility of developing this iatrogenic form of the long QT syndrome due to the therapy that is provided by hydroxychloroquine and azithromycin, which are really popular today in the COVID positive patients. So tell us if the athletes with this middle form of the infection actually develop this prolonged QT syndrome. So this is something that is new for them. So they are not really used to deal with it. So after those 2 weeks that they wait after the symptoms are done, how careful should we be with their ECG and any kind of electrolyte disbalances, because any kind of hypokalemia or hypocalcemia can trigger some of the life-threatening arrhythmias?
Yeah, so actually the concomitant administration of hydroxychloroquine and azithromycin has been associated with really severe prolongation of long QT in some people who was not known to have the disease, to be a long QT syndrome patient. So the recommendation is to do an ECG at the beginning of the treatment, before start the treatment, and have a new ECG after 24 hours, evaluate changes on the QT, and especially those prolonging over 500 milliseconds. We should be more concerned on these cases. If prolongations are over 500, risk for development of ventricular arrhythmias in these cases is slightly higher. So they should be very close monitored. They shouldn't be taking the medication and stay at home. Not at all.
Okay, Okay, so thank you. That was a question coming from me. There is no more hands raised or anything in chat. So we have applause coming from Milena as a reaction. So it was really great to be here today, and thank you very much for finding time for our forum. I think your lecture was really precious to all of the participants in today's audience. So we have answered to a lot of doubts listening to you today. And I hope that we will continue our collaboration in the new season of the forum that is starting in autumn. It was really interesting. We have people coming like from Latvia, the entire Balkan, from Doha, from Dubai. So it was really one multicentric online Congress lecture, we can say today. And thank you for being there for us and providing us this. I also want to thank the entire audience for being here week after week. So we were here more than 2 months for this forum. I think it was really great to start something like this, and we will see again starting from October.
Well, allow me to thank you for the invitation. It has been really a pleasure to be here today with you in this forum. I'm really impressed with the organization and also with the level of the forum. I'm really very glad to be here. Thank you for the invitation.
And thank you for joining us. So I wish you all the nice evening, and see you again starting from the next season. Bye.
Bye.